Good afternoon, folks, again. So I'd like to thank Professor Hodkinson for inviting me to this great institution. I've been here for a day and a half, and I've thoroughly enjoyed my short stay here and teaching students and fellows. So thanks, Bridget. Of course, Bridget can be difficult as well. She can be uncompromising, and she's asked me to do a talk as well. So I thought of talking on systemic sclerosis, which I think I know a little more than most people, but not everything. Now, it's frozen on this side, folks. I don't know what's happening. Okay. So I have no disclosures for this for this lecture. However, I would like to dedicate this lecture to my mentor, Professor David Bloomston, who's a great and wonderful teacher, taught me medicine and many other things. Sadly, he passed away about 3 weeks ago at the age of 89. So briefly, what is scleroderma? So scleroderma or systemic sclerosis is obviously a connective tissue disease, and we all recognize the problem of fibrosis of the skin. However, in recent times, we've come to appreciate the microvascular and to some extent the macrovascular changes that occur in this condition, and of course the inflammatory autoimmune features. To begin, I think it's important to recognize the contribution of South Africa in the understanding of systemic sclerosis. And it was here in Cape Town that a German vascular surgeon, Robert Gertz, first made the observation that systemic sclerosis is not skin deep, but goes beyond that. And he did autopsy studies on several patients who had systemic sclerosis or scleroderma at the time, and was able to show that there's fibrosis not only in the skin, but also in the lung, and there were changes in the intestines, as well as the vascular changes, which is shown very nicely in the photomicrograph on the right bottom section. And I'll come back to that in a little while. So in terms of the pathogenesis, we now recognize that besides the fibroblast, endothelial cells play an important role, and the B cells and T cells are clearly important from an immunological. I beg your pardon? Sorry. So the important aspect of the pathogenesis now is that we think the primary insult is at the level of the endothelial cell, and that in some way affects the fibroblast, such that the fibroblast takes on a phenotype of a myofibroblast, and the myofibroblast is responsible for the extra collagen that's deposited in various tissues. Now, this is probably the most important slide that I'm going to share with you, and this is the concept was developed by Tom Metzger from the University of Pittsburgh. Pittsburgh has done much work on both the clinical and laboratory aspects of scleroderma, and I'm going to spend a little bit of time on this. And basically what this slide shows is the differences in terms of the clinical spectrum, and also the trajectory of skin changes in patients with diffuse disease and limited disease. So just to start off to say that diffuse disease, by diffuse disease, we mean involvement of the skin, and there is dermal thickening that extends beyond or proximal to the elbows or knees, and invariably affects the trunk. Whereas in limited cutaneous disease, it's usually distal acral disease, but it can also affect the face. When we look at diffuse cutaneous disease, there are certain features that are more prominent and occur more frequently in the early course of the disease. And those include particularly renal, scleroderma renal crisis and interstitial lung disease. And as you can see also from the curve in terms of the skin involvement, that with time, and usually around 5 to 6 years, there is natural healing or regression of the skin dermal thickening. And this concept was really not understood well enough in the past, such that when trials were done, we often took patients that had long-standing disease, in which case the skin was regressing, as part of the natural course of the disease. And of course, that created problems. And because of our better understanding now, at least clinical trials that have looked at systemic sclerosis have been confined to patients with early disease, usually less than 5 years, but going up to 6 years. And as you can see, interstitial lung disease occurs somewhere in that period. Limited cutaneous disease, on the other hand, is much more indolent. Of course, esophageal disease can occur, and pulmonary hypertension is a major complication that occurs in late disease, in roughly about pulmonary arterial hypertension, that is to say, in about 10% of patients beyond 9 or 10 years. And what you notice here, there is no mention of the term crest, and the term crest is no longer used because the crest features can actually occur in both limited disease as well as diffuse disease. And one of the things that I want to point out today and put some emphasis on is that whereas in the past we thought of limited disease as being mainly a vascular disorder and diffuse disease being predominantly a fibrotic disorder, I will show you in a while that the vascular abnormality in diffuse disease can be profound. Okay, so within the patients who have diffuse cutaneous disease, we have two subtypes, right? And the interesting thing is that these antibody serological subsets are mutually exclusive. So if a patient has anti-topoisomerase 1 antibodies, previously known as anti-Sclerosis antibodies, they almost invariably will not have anti-centromere antibodies, and likewise they will not have anti-RNA polymerase 1 antibodies. So the group that does worst of all is the group that has anti-RNA polymerase 1 antibodies. These are patients who have rapidly progressive skin disease and at greatest risk of scleroderma renal crisis. Anti-topoisomerase 1 patients have moderately progressive skin disease, and they are at risk of developing interstitial lung disease. And finally, the anti-centromere antibody group have indolent disease. And as I mentioned to you, the major concern with these patients later on in the course of the disease is malabsorption and pulmonary arterial hypertension. Okay, so this is just a histological representation of the skin fibrosis. I'm going to talk a little bit more about this in a moment. Right, so, at a histological level, what we see here, if you did a biopsy, say, of a digit, is it's indistinguishable in terms of diffuse versus limited cutaneous disease. However, if you do more fancy things like that's been done recently using microarray and looking at gene expression studies, we in fact find that there are 4 intrinsic subsets of the disease. So in most patients who have limited disease, they will have a normal-like gene expression pattern. Then you get a limited pattern, an inflammatory pattern, and a fibroproliferative. And the inflammatory and fibroproliferative patterns usually are associated with diffuse disease, as I will show you in a moment. Okay. And more recently, what's been shown is, as I mentioned, that the normal-like intrinsic pattern is associated mainly with limited cutaneous disease. And also those patients who have normal-like gene expression will have a longer disease duration. And again, it goes with the fact that these patients have a long indolent kind of disease, okay? What's more interesting is that if you look at the skin patterns in relation to antibodies, you find that patients who have the anti-RNA polymerase 1 antibody are likely to have more of the inflammatory picture, fibroinflammatory picture, and those with the anti-topoisomerase 1. Sorry, it's the other way around. The patients with RNA polymerase 1 will have more of an inflammatory picture, whereas the patients with anti-topo will have more of a fibroproliferative pattern. Okay, so we're now beginning to understand the differences in terms of gene expression, and this has a bearing on which therapies work, and I will show you something around this in terms of the use of mycophenolate in a moment. So the other area that I want to highlight is the area of digital ulcers. Now, one of the paradoxes that we really didn't appreciate in the past was that patients with diffuse disease are more likely to have digital ulcers. And I think our experience at Barra is probably similar to the experience you have here, that patients with diffuse disease come with these ugly ulcers, and sometimes they develop gangrene and so forth. And one would think that, it would be the patients with limited disease who develop this. And there have now been several studies showing that patients who have these digital ulcers not only have microvascular changes, and the microvascular changes, as we know, are reflected in the navel papillary changes, but often these patients have macrovascular disease. And I will show you some studies looking at the relationship of, at least one study looking at digital ulcers in relation to peripheral vascular disease. But what's also interesting, and this is an observation one of my colleagues made, Dr. Claudia Ickinger, who studied 9 patients with ulcers and found that I think 8 of the 9 patients had a cutoff at the ulnar artery in the mid forearm. And this has now been replicated by other people and been published. So there seems to be a significant, when patients develop these severe complications of peripheral vascular compromise or ischemia, invariably they also have large vessel disease. And I think this is an area that's going to be looked at in future. And it's not surprising, therefore, that even drugs like the endothelin receptor antagonists, whilst they prevent new digital ulcers from occurring, they are the endothelin receptor antagonists do not help or hasten the healing of digital ulcers. And I think it's largely due to the fact that there's large vessel involvement. Okay, and I don't think this slide projects very nicely, but what I wanted to show you, sorry, one moment. If you can, so this is a study in which they looked at over 1,000 patients with systemic sclerosis, and they divided them with respect to those that had digital ulcers versus those that didn't have digital ulcers. And I think the point I want to points I want to highlight here is the fact that if you look at the patients who had Sclerosis positivity, right? That's on anti-topoisomerase 1 antibody positive. Something like 19% had digital ulcers, right? Sorry, 19% of the patients with digital ulcers had Sclerosis antibody positive, whereas those without digital ulcers, only under 10% of them had. Now, this was clinically significant. And we can see in terms of telangiectasia as well, a similar difference. Those with digital ulcers are more likely to have telangiectasia, more likely to have calcinosis. And by the way, the calcinosis and digital ulcers are often occurring together, like in the picture that I've shown. Calcinosis actually represents partial healing or dystrophic calcification from the ulcer. So it's not surprising that calcinosis occurs more commonly in patients with digital ulcers. The other point I want to highlight here is that if you look at the comorbidities in terms of peripheral vascular disease, much more common in patients with digital ulcers versus those without digital ulcers. And what's also interesting is that although as I mentioned to you, the studies have shown ulnar artery abnormalities in the forearm. When you do IMT studies seem to not show any abnormalities in the aortic arch area or the carotids, but rather we see IMT thickening more in the lower limb vessels. So that's interesting as to why there's sort of a selective intimal thickening occurring more in the lower limbs than the upper limbs. So it's really an interesting area. I think it's changing our understanding of the vascular abnormalities. Firstly, we're seeing that patients, it's almost counterintuitive that patients with diffuse disease are more likely to have severe vascular, at least systemic vascular disease, as well as the fact that digital ulcers, and that peripheral vascular disease occurs more commonly in patients with diffuse disease. Okay, so here's a study that's been done locally by Claudia Ickinger. Claudia is doing this work as part of a PhD. This is a new technology that's been used to measure peripheral blood flow. This equipment was brought out by a group of people from Belgium, and we were only able to do 40 patients, and we compared our data to their data from Belgium. And again, this is somewhat surprising. So the image on the left shows the technology and how the flow is measured. And as you see on the graph or the histogram, the box plot on the right, you can see that patients with our Black patients with systemic sclerosis have significantly lower flow rates compared to Caucasians. Of course, these measurements are done under controlled conditions. The temperatures are regulated and so forth. So it's not the influence of ambient temperature. But going down to the table, if we look at white females as the reference, right, we see that there isn't much of a difference in flow rates between white females and white males. And in fact, the subgroup that does worse in terms of flow is Black males. And I think this is, our sample size is small, so we can't do much more data analysis. But this probably reflects the fact that Black males are predominantly patients with diffuse cutaneous disease. So again, making the point that diffuse cutaneous disease is actually associated with the worst type of peripheral blood flow. And it ties in nicely with what we're seeing in terms of digital ulcers. Okay, so moving on to the systemic sclerosis associated interstitial lung disease. As we know that, and this slide, sorry, I probably missed one of my slides, but there have been very good studies done again in Pittsburgh and in Washington, where they've shown that over a 20-year period, the causes of death have changed significantly. So in the old days, in the pre-ACE era, scleroderma renal crisis was probably the commonest cause of death. But in the post-ACE era, the ACE inhibitor era, we find that the predominant cause of death is either interstitial lung disease in patients with diffuse disease or pulmonary arterial hypertension in patients with limited cutaneous disease. And you can see from this summary slide here that in autopsy studies, at least 75 to 95% of patients will have lung changes. At a clinical level, we see that in about 50% of diffuse cutaneous systemic sclerosis patients will we see ILD and much less in limited cutaneous disease. One of the things that's just as an aside is that patients with limited cutaneous disease who are anti-centromere antibody positive are protected against interstitial lung disease. We don't know the mechanism, but it's almost unheard of. Patients with anti-centromere antibody disease will complicate with ILD. Now, in terms of the histology, the majority of patients with systemic sclerosis associated ILD will have non-specific interstitial pneumonitis. This is in contrast to rheumatoid patients where the vast majority will have UIP. And as we know that NSIP response is probably immunosuppressive than other subgroups.
Yeah, after switch out, yeah.
Okay, so this is just showing a high-resolution CT scan of a typical NSIP pattern in one of our patients. Yesterday we talked about at the combined meeting with the pulmonologist about how we assess risk. And as was discussed, not all of the patients, in fact, only a minority of patients with interstitial lung disease, scleroderma-associated interstitial lung disease, will go on to develop or will have progressive disease. And this is the GO staging criteria. This was developed by a group at the Royal Brompton Hospital, led by et al. Wells, whom I think many of the pulmonologists know. And this was really to simplify for the clinician how to assess and introduce immunosuppressive therapy. Some of you might recall that there was a very complicated scoring method for high-res CT scans developed by the late Turner Warwick, and that's really not practical in the clinical setting. So what this shows is that patients with extensive disease, and extensive disease here is where you have more than 30% of the lung involved on HRCT, and where the forced vital capacity is less than 70%, those patients are much more likely to progress. And those patients who have less than 10% involvement on high-res CT, and where their FVC is greater than 70%, those patients are defined as limited disease, and those patients have a much better prognosis. Of course, there's a large intermediate group, and I think in terms of the current trials that are going on, many of these intermediate patients are now being included with the extensive disease group and are included in clinical trials. Okay, so many of you know this study. It's from a while ago. This is the SLS1 study, which looked at which compared cyclophosphamide to placebo and showed that cyclophosphamide was superior to placebo in interstitial lung disease associated with scleroderma. What is important here to recognize is that when we talk of a response to therapy, it simply means stabilization of your FVC. And if you're really doing well, you'll get an increase of up to about 15% in your FVC. And that's all we expect. And I think because of this, we're now lowering the bar in terms of introducing immunosuppressive agents. I'd like to point out here that, in the past, we put much more emphasis on the DLCO transfer factor, but that's less reliable, and there's much more of a problem with reproducibility. So in terms of lung function tests these days, it's the FVC that's used as the outcome measure. Of course, there are other clinical outcome measures like the 6-minute walking distance that's been used, the Borg respiratory rating, etc. Okay, then want to really move on to what I call super M, mycophenolate. And mycophenolate, I think, has really changed the way we manage patients with systemic sclerosis. And this is the SLS study that showed that, like in lupus nephritis, MMF was equally efficacious as oral cyclophosphamide. I should add that this was an American study where they used oral cyclophosphamide, but similar studies were done in the UK where they've used IV cyclophosphamide as well. So there is still the choice of using either IV or oral cyclophosphamide. I think the thinking in the UK was that IV cyclophosphamide was associated with less toxicity. So we see from here that both mycophenolate, mofetil, and cyclophosphamide produced a response, although most of them just had stabilization of the FVC, but in fact some of them had up to a 15% improvement in the FVC. Okay, just to talk briefly about the FOCUS study. This was a study that was sponsored by it was industry-sponsored study called FOCUS, and this was a randomized double-blind placebo-controlled study where tocilizumab was tried. It was based on some anecdotal experience with tocilizumab, and of course we all know tocilizumab. I should like to point out to non-rheumatologists that tocilizumab is not an IL-6 inhibitor, it is an IL-6 receptor antagonist. IL-6 inhibitors haven't been shown to be that effective in terms of immunomodulation. So it's an IL-6 receptor antagonist. And what we see here, it's almost a probability, like a probability curve that's been shown here, is that patients with scleroderma-associated interstitial lung disease are much more likely to have stabilization or improvement in the FVC as compared to patients on placebo. Because the drug is readily available, at least in South Africa, it's an option that we should consider. Of course, there's been a lot of hype and a lot of excitement about the use of the tyrosine kinase inhibitor, nintedanib. This is work that's been done. It's mainly an international study of European and US patients, and again showing that nintedanib is superior to placebo. But just to point out that this drug is extremely expensive. I'm told that it costs 40,000 rands a month in this country. And so I don't think it's really an option for our country. And also to point out that, it's not a drug without side effects. And just to show you that that these patients can have, up to 70% of these patients can have side effects such as diarrhea and so forth. When they've done a further sub-analysis, it seems that the risk of side effects is obviously less with a smaller dose, but also that the impact on forced vital capacity is not compromised with the lower doses. So we might see changes in dosage regimes with the treatment of nintedanib in patients with systemic sclerosis. Okay, so I want to, so this slide here takes me to what I want to spend a few minutes on, and that is the role of systemic sclerosis. Mycophenolate in systemic sclerosis. So this is a study that was published in 2013 by a group led by Michael Whitfield at Dartmouth in the US. And what they were able to show is that patients who improved on mycophenolate in terms of the skin had an inflammatory signature. So you recall I talked about the 4 different signatures, the gene expression signatures. And so they were able to show those who improved were much more likely to have an inflammatory pattern, whereas those who didn't improve were more likely to have this sort of fibroproliferative. So, we're getting closer and closer to what we call personalized medicine. But, doing these studies at a clinical level as part of routine medicine is probably not on for the moment. But that's probably where we're heading. Okay. And then why I'm so excited about mycophenolate is that this is the census study. This is the study where nintedanib was used. In the study, 45% of patients were on background mycophenolate. And when they then looked at the response to therapy with respect to patients on mycophenolate or off mycophenolate, what they were able to show is that the patients, and you can see this, the blue solid line here, patients who are on mycophenolate at baseline, in combination with nintedanib did best of all, okay? Whereas the patients who had no mycophenolate and no nintedanib did worst of all. So there's now a third study that's going to be looking, the SLS3 study, which is going to be looking at pirfenidone in combination with mycophenolate. So it looks like we're going to have to combine, if we can afford it, an antifibrotic agent together with an immunosuppressive agent. And this is further confirmed by another study. Now, there's been a small company in the US led by a rheumatologist that has been investigating the role of cannabinoid 2 receptor agonist called lenabasum, right? And in the phase 2 trial, this drug was shown to actually have benefits in terms of the skin and lung function tests. And in the phase 3 study, they actually had to they had to stop the trial because there was no difference between the study arm. In other words, patients on the cannabinoid 2 agonist versus those who were on placebo. And then further analysis, and this is very interesting, I've tried to highlight this, that if you look at the patients who did worst of all or had the least response, are those patients, IST refers to immunosuppressive therapy. So patients who were simply who didn't have background immunosuppressive therapy had a response, but the ACR CRIS score, that is the improvement, the ACR CRIS score looks at sort of 4 domains in terms of scleroderma, so it's a response criteria. These are response criteria. You see an improvement. However, patients who were on MMF, but not another type of immunosuppressive drug, did best of all. Okay, again, making the point that mycophenolate is really really an important drug to be used in this condition. And what's important also to remember is that the improvement was not only with respect to the skin, it was also with respect to the FVC, as well as improvement in the head disability index. So I think we're going to see a lot more on mycophenolate, having recently attended the visual meeting, the ACR, I think there's a strong swing to use mycophenolate in preference to cyclophosphamide. I think cyclophosphamide still has a role to play, but it seems that over and above the immunosuppressive effect of mycophenolate, it also has an antifibrotic effect. I just want to clarify one thing. It's a question that arose yesterday, is that I think we're seeing similar kind of regimens being developed for the treatment of interstitial lung disease in scleroderma as in lupus nephritis. It's really important that we have 2 phases in the treatment. There's an induction phase. And I think in the induction phase, both cyclophosphamide and, the 2 drugs, cyclophosphamide and MMF are probably equal, as I've shown you before. But in the consolidation phase or maintenance phase, it's really important beyond 6 months to continue either azathioprine or MMF. MMF has been shown to be somewhat superior, statistically significant superiority, but I don't think that really matters. Of course, there's a cost issue for us in South Africa, but it's really important. The earlier studies with cyclophosphamide, where the drug was stopped at 6 months, showed that patients deteriorated rapidly thereafter. So at least 2.5 years of therapy is required for patients who have scleroderma interstitial lung disease. Okay, I'm going to skip the slide in the interest of time. I want to then just turn to a paper that I co-authored with people in Switzerland. They did the work, a lot of the work. I just had to sort of give them some insights into what they were doing. So this was to review all the cases and publications of systemic sclerosis in Africa. And just to make the point here that the majority of patients in Africa have diffuse cutaneous disease. We showed this several years ago. It was really not recognized. This is very different from the Caucasian population. In Caucasians, it's the reverse. 2/3 of patients will have limited cutaneous disease. And also important to recognize that scleroderma renal crisis is actually rare in our setting. And the reason I believe, and we've got data, I'm not showing this here, is that the RNA polymerase 1 antibody is extremely rare in our population. And we actually don't see much of the very rapidly progressive form of diffuse cutaneous disease. So that's good for us. But having said that, it does occur. And just to remind people that scleroderma renal crisis can be precipitated by high-dose corticosteroids. And so we advise not to use corticosteroids in doses greater than 15 milligrams per day. Okay, so this is important. We sometimes are forced to use higher doses because, again, patients of African extraction tend to have more inflammatory features. So we're more likely to see serositis in these patients, more likely to see myositis. And of course, there we need to use the corticosteroids with caution. But it does occur, although I think people of African extraction are less at risk for this terrible complication. Okay, and then I want to turn to the autoantibodies. Now, you might recall from what I said earlier that in Caucasian populations, in 80% of patients, they segregate into 3 main groups: the ECA positive, which is limited cutaneous disease. Then the diffuse, there are 2 groups there: the anti-topoisomerase group, or the ETA group, which is associated with interstitial lung disease, and the ERA group, or anti-RNA polymerase 1/3 group, which at a clinical level is associated with the scleroderma renal crisis. However, in Africa, we don't see that pattern. And we've done studies with people in the UK. They've done immunoblot assays rather than ELISA tests, and in fact shown. What I want to highlight here is that the commonest antibody on the African continent associated with systemic sclerosis is the antifibrillin, or U3-RNP antibody. And I've just shortened this for EFA, which is very appropriate for Africa. So EFA antibodies are associated with Africa. As I showed you, it's about almost 20% of patients will have this. And it's reflected on ANA as a clumpy nucleolar pattern. Unfortunately, our labs here do not do this kind of fine separation of the nucleolar pattern. This is associated with diffuse disease and associated with the salt and pepper depigmentation that we so often see in our patients. And this is a example of a patient that I looked after. These patients are also more likely to have a myopathy or myositis. And interestingly, these patients, although they have diffuse disease, are also at risk of developing pulmonary arterial hypertension. And finally, just to say that small bowel involvement is very common. And, there's been a lot of recent literature on bowel problems in patients with systemic sclerosis. I don't have the time to go through this, but there are now specific questionnaires regarding the patient-reported outcomes with regards to bowel involvement. So a lot of these patients who have this antibody, the FI antibody, will complain of early satiety, bloating. It's usually, mid-gut problems that they have, apart from the reflux and so forth. So we also reviewed that the treatments that are being used in sub-Saharan Africa, most patients were treated symptomatically with NSAIDs and PPIs for reflux, and I don't think the latter is a bad idea. Right, and 2 large studies from Kenya and South Africa reported prednisone and prednisolone use, and that's a little alarming that we're using, so much of corticosteroids. What's more alarming is the fact that relatively high corticosteroid doses were used between 40 and 60 milligrams per day in some of the studies. Methotrexate was used in 5% and 22.5% of the 2 studies. I should add here that methotrexate probably, especially the patients with just skin disease and no interstitial lung disease, I think if you've got diffuse disease, we need to introduce the immunosuppressives early. That's there aren't any formal studies, but certainly the sense I get from world experts is that in diffuse disease, we should be introducing an immunosuppressive agent, either methotrexate or mycophenolate early in the course of the disease. So we clearly underutilizing methotrexate here. And of course, it's a cheap drug, so we should be looking at using more of the drug. Okay, the other drugs have been used. We don't use depenicillamine anymore. It's not available, although earlier reports suggested that it was protective against visceral involvement. We have no studies in Africa or no reports of the use of stem cell transplantation. Autologous stem cell transplant has been studied widely in Europe and North America. We haven't had any reports on use of biologics like tocilizumab. I should say that the other favorite of the rheumatologists, vitamin R, has got a role in the treatment of systemic sclerosis. The reason we call it vitamin R is that although we started using it in rheumatoid arthritis, we find it to be very useful in many of the other connective tissue diseases. It's been extremely helpful in the setting of systemic lupus, where especially patients who have hematological problems like immune thrombocytopenia, the drug works effectively. In scleroderma, it's been found in small studies to be useful for the skin, although the effect on lung involvement seems to be minimal. So we have some of these biologics, and I think given the fact that rituximab is not associated with an increased risk of tuberculosis, it's something that we should consider in our patients. I think there's a lot of work still that needs to be done in Africa. We really haven't studied or used patient-reported outcomes in our patients. There have been very nice questionnaires that have been developed for the self-image in scleroderma patients, and showing that the facial changes, the pigmentary changes affects patients' well-being. And I think we should be doing those kind of studies here as well. So there's a lot of scope for doing research in systemic sclerosis in Africa, particularly because we deal with the more severe variant, that is diffuse cutaneous disease. So in conclusion, thanks very much for allowing me to share my excitement around systemic sclerosis. Just to highlight some of the features that I've mentioned. The diffuse cutaneous is more common in our population. FI is common. FI is associated with diffuse disease in our patients. And most patients, and I didn't show you the data on, we've done some work on causes of death, but the majority of patients who die with scleroderma who die prematurely are due to, the majority of the patients die because of cardiorespiratory complications. And we need to use our limited resources in terms of therapies better. And I don't think the more fancy therapies will be available readily in this country. So thank you very much.
Great. Well, thanks very much, Prof. Tikly. We much appreciate your talk, and we also appreciate your traditional, your barrier resilience at putting up with the technical problems, and I'm sorry about those. And thanks also to Prof. Joel Day for bailing us out. I have one question, if I could kick off. I just want to ask you about the digital ulcers and the ulnar nerve, the medium vessel problems. Does that mean we should be doing angiograms on all our patients? Does that mean we should intervene? Do you know?
The studies that have been done in terms of vascular intervention, I think it's just an observation that's being made. There have been histological studies showing fibroproliferative changes of the arteries. I'm not sure whether the statins are going to make any difference in these patients. It's an interesting question, but I don't know. I've looked at the literature. I haven't seen anything more recent. just to important to say that the terminal ulcers can be extremely difficult to manage, and we have to advise our patients to avoid any injuries to the digits.
So I think Dr. Tikly has a question.
Thank you, Prof, for, such a lovely talk. I just wanted to ask, regarding patients with, when you showed, the lung involvement, and then, patients, with involvement on HRCT that is less than 10%. So if, a patient has got that, and then the FVC is more than 70%. It's fine, to say this patient has got limited disease, and then you follow them up. So what happens if, the FVC is far less than 70%, but they only have 10% involvement of on the HRCT? If that, makes sense.
I'll answer this question. I think our pulmonology colleagues are probably better equipped to answer the question. I must say, that sort of scenario is unusual to see FVC that's less than 70% in lung field. Sorry, the FVC. Less than 10% involvement with a very low FVC. I think you might see that with vanishing lungs in patients with systemic lupus. But maybe our pulmonology colleagues can comment.
Well, perhaps I can call on Prof. Dida, who is going to ask the question, but we'll catch him and get him to answer that.
Thanks. Thanks, Mohammed. That was a really fantastic talk, and you covered so much of ground. I won't spend much time answering that question, but I think, Ayanda, I would take a clinical approach and look at progression over a 6 or 12-month period, and use what we normally do is look at symptoms and lung function, and I think that's how I would answer, handle that particular subgroup. It's an uncommon subgroup that we see, but that would be the basic approach. In terms of moving on to Mohammed, to ask you two questions. The one thing the first question is about the gastroesophageal reflux disease and that component of disease. And we have a lung transplant program here, and we have a number of young patients with end-stage lung disease who are candidates for lung transplantation. And the hurdle really, or the deal breaker, is the gastroesophageal reflux disease, because these patients, once they transplanted, we're told by the transplant team that they do very poorly because of ongoing reflux and destruction, rapid deterioration in the transplanted lung. So, are there any advice, or are there any advances in that area, either in terms of surgical or minimally invasive options or medical therapy? Any advice? Because we have a number of young patients who fit into this category, and then we cannot offer them lung transplantation. So I think that would be the first question.
Just to say that I think there have been studies, observational studies, looking at the relationship between the degree of reflux and lung disease, and certainly there is a relationship. So the more reflux you have, the worse the lung disease. And equally, there have been studies showing that over and above the immunosuppressive that we use, PPIs reduce the risk of progression. So that's been done, and I think that's the general recommendation. Patients with scleroderma-associated interstitial lung disease should be on a PPI. As far as surgical intervention, it's a great question. What's the literature saying in IPF? Is there literature suggesting that surgical procedures should might make a difference?
Yeah, they ask. I mean, our gastroesophageal surgeons do offer, intervention if you prove reflux in that situation. But the problem here is surgically, there's no options, because of this sort of lead pipe esophagus where, Nissen is not offered. So we have a number of patients who fall into this category where there are no surgical options for them. But I just wondered whether there was something innovative with all this, the invasive approaches and things that you may have heard of.
We don't have much transplantation, to be honest.
Right.
But it's a great question. If I do find something, I'll certainly forward it to you.
Okay, thanks. And then the other quick question I had was, about combination therapy. Again, in patients with chronic interstitial lung disease. And, as you said, nintedanib is not accessible to most of our patients, very expensive. And you showed that the very nice data about the combination of mycophenolate and nintedanib. So in other words, combining two agents in patients who, are not responding, patients with interstitial lung disease who are not responding to medical therapy. And what is your experience with combining agents? I mean, agents that are accessible to us and affordable would be things like cyclophosphamide, methotrexate, and mycophenolate. And are you guys doing anything in clinical practice? Are you combining two agents, for example, in people, who don't respond to monotherapy? Is that, we're not doing it here, but I just wanted to know what your experience was in combining two, immunomodulating agents to treat interstitial lung disease. Thanks.
Yeah, so I don't think we would use two immunosuppressive. In principle, that's not a good idea because of the risk of infections. The only setting where we would be using combination therapy, and it's for a slightly different reason, is if we are considering rituximab, and in patients who are on rituximab, co-prescribing something like methotrexate helps to reduce anti-drug antibodies. But outside of that, I don't think using cyclophosphamide in combination with MMF has ever been done. I mean, the first studies of cyclophosphamide in lupus were in combination. The combination therapy was actually with rituximab, way back in the early 2000s. But no, I wouldn't advocate combining two immunosuppressive agents.
Yeah, and what about the combination that you showed us data on, MMF and nintedanib, for example? The problem we face is we put a lot of these patients on some kind of therapy, and then you find after 12 to 18 months, there's no response and progressive disease. And then one wonders after 12 months, can we add something else?
Yeah, look, I think nintedanib is not going to be readily available in the state sector. So, it's very much a theoretical issue. I must say, if you look at the pathogenesis of fibrosis, and it's a talk on its own, that and I've just toyed with the idea that PPAR gamma agonists actually are anti-fibrotic. And, the PPAR gamma agonists that are used in the treatment of diabetes, I've always wondered whether we can't, combine in small doses. These are not studies that are going to be done in the first world because, they have much more sophisticated targeted therapies. But maybe in our setting, that's something that we can think of.
Yeah, thanks so much. I see Mark Blockman has a comment and maybe on nintedanib, so maybe I'll pass it on to him. Thanks.
Well, Mark has just agreed to pay for nintedanib for all our patients. But I think Prof. Mashiko Seshedi, who's head of GIT, she's got some questions and some answers for us.
Ketan raises an important point about poor mobility and mortality in patients who've had a lung transplant who have GERD. And what he was asking was whether there's any novel or newer therapies. PPIs are effective, as Prof said, but unfortunately the effect does wane over a 12-month period. Anti-reflux surgery has been discussed in some of the guidelines, and there are some suggestions that it can improve outcomes, but that's still out there. I think the jury's still out about long-term what the effects would be, because as you said, because of the stiffness of the esophagus, it's not pliable, so a Nissen may be problematic. I think the thing to do, and I think that's what we do here, is to find these patients pre-op treat their GERD symptoms. And if it's not done pre-op, it can also safely be done post-op and PPIs and monitor the patients. But yeah, the jury's out on whether surgery actually improves their lot.
Thanks, Mashiko.
Yeah, just to add, I mean, as a follow-up to what Professor Deda has been talking about, I mean, we have the same problem with pulmonary arterial hypertension here, don't we? I mean, you know, at best we'll get sildenafil. There's some evidence in scleroderma-associated PAH that adding warfarin might be, you know, helpful and reduce the risk of progression. But all the other, you know, endothelin receptor antagonists and the prostaglandin analogs, we don't have them here. You know, ipoprostenol is extremely expensive. So this is a hugely unmet need. And the trouble is, scleroderma is such a rare condition. So, you know, it's unlikely that these drugs will be brought into this country. I don't know what you think about it, but that's the problem we face here.
So I think Prof. Khumalo has a question. Prof. Khumalo is head of dermatology. Or a comment?
Thank you, Bridget. Thank you. I thoroughly enjoyed the talk, and I really like the idea of moving away from the focus on fibroblasts to other, you know, potential contributors to the pathogenesis. I think it's a thing that is growing, looking at the endothelial cells and myofibroblasts to see what effect they are having in the pathogenesis. And I think that is quite helpful. I just have two main comments. The first one is about the laser speckle analysis for vascular flow. Mm-hmm. And I think your results suggest that patients of African ancestry had the lowest flow there. And I don't know whether they've done any work to validate the tool in pigmented skin, because lasers are notoriously confounded by pigmentation and various things. So for instance, even for hair removal, you tend to find that where you've got a lot of melanin, the laser will be a lot more effective than when you don't have melanin, because there the melanocytes are the chromophobe. But with vascular lasers, your chromophobe is going to be generally hemoglobin. And how well the laser penetrates and identifies the hemoglobin might be influenced by how much melanin is in the skin. So it's just a caution, just to find out whether the tool that was used has actually been validated for pigmented skin.
Yeah, it's actually a great question, and we've been trying to grapple with this. You know, unfortunately, when the equipment was brought over, the folks or colleagues from Belgium were only here for a week, and one of the things we overlooked was to include a control group. You know, a paper that we looked at in terms of reproducibility of the technique, the reviewers made the very same comment you're making. However, there is the positive side to it, that when we did flow on the volar surface versus the dorsal surface, there was not much of a difference. And if pigment was such an important component, then you'd expect the flow rates to be significantly different on the dorsal surface where there is more pigmentation compared to the palmar surface. So that's all I can say in defense. You know, we've asked this question, we've talked to people, medical physicists and so forth, whether this is, you know, whether the pigmentary changes do influence laser flow. And, you know, I think, again, it brings out the point that, sorry, I might sound political here, but, you know, things that are done in the West and predominantly in Caucasian populations are taken to be gospel truth. And it doesn't necessarily apply to us. And I think, you know, that's the sadness for me, that, you know, in the studies that looked at the self-image, only 2% of the patients, for instance, were of African extraction. 98% were Caucasian. And so what does it tell us? You know, You know, when pigment is so important, and specifically because many of our scleroderma patients have this salt and pepper depigmentation. So, you know, you raise an important issue, and maybe that's the reason we need to drive the research from here. Unfortunately, this equipment is extremely expensive. And, you know, just to have it sent over, you know, by freight, it was a major mission. So you raise an important question. I don't have the answer. It's out there for debate, but a very important point. Thank you.
Thank you. I agree with you totally there. But I think we should be doing our own studies and raising funding to do the studies. I think it is possible. The last comment I just wanted to make is I find scleroderma very frustrating to measure whether people are actually getting better or not. From the point of view of the skin, I don't know, you know, the skin scores that we have just don't seem to be good enough. Is there a sense from the literature that there are clear there's a clearer way of measuring outcomes in terms of number needed to treat? Because these therapies are very expensive. And I think there is a need for us to try and justify what we're doing. So, and I guess that will be by discipline. But are there any guidelines of how many patients do you need to treat to prevent this renal crisis, for instance, or to prevent, you know, are the treatments worth it? That's what I'm saying.
Yeah, I think in terms of renal crisis, we still have unmet need there. That although we've you know, significantly reduced the risk of chronic renal disease in these patients and death, there are a substantial number of patients who still don't recover in terms of renal function. And again, here, you know, the prostanoids have been tried in addition to the ACE inhibitors and so forth. So yeah, in terms of the skin, that's a very interesting question. So I've been, you know, involved with the USTAR group, and the USTAR group is the European Scleroderma Trials Group, and we happen to be the only center that contributed. So we had to go through training, and the skin scores. The problem is many people misinterpret the skin changes. So we're looking at dermal thickening. We're not looking at induration of the skin. That's the first point about it. The second thing is that even in experienced hands, the intra-rater reliability, right, is up to 25%. And that's the problem. So you need to have more than a 25% change, right, to make a call that, you know, things are getting better or worse. And in several of the studies, they've gone back and looked at the skin scores, and they're all over the place. You know, some get better, some get worse. It's really a problem. And the other problem, and I didn't have time to discuss it, is that like in lupus and rheumatoid arthritis, we have scores or ways of differentiating between disease activity and damage, right? So in lupus, we have the SLEDAI to assess disease activity, or the BILAG, and then we can have the SLIC to assess damage. In scleroderma, you know, especially with respect to the skin, how much is damage? In other words, how much is disease activity? In other words, potentially reversible, versus how much is damage where it is irreversible. And that's a major problem. And I think for the lung, it's the same issue. You know, what we're seeing on the high-res CT, is it all inflammation when we're seeing ground glass? My understanding is ground glass doesn't necessarily translate to alveolitis, right? And what we see as fibrosis is that, you know, irreversible fibrosis. So that's a real problem. But I think the ACR CRIS score has to some extent overcome that. And in many parts of rheumatology, composite scores seem to work better than a single measure. We see that with rheumatoid arthritis, where we use the CDAI or the SDAI. We see that in lupus as well. So, but as you say, it's much more of a challenge in scleroderma. You're absolutely right. We don't have a way of assessing disease activity. And remember, the CRP ASR only, you know, are increased in only about a third of patients. So the acute phase reactants are not a very useful marker in terms of disease activity. Thanks for the question.
Right. So I think in the interest of time, I think we have to wrap this up. But thanks so much to Prof. Tikly, and thanks to all of you for your attention, and I wish you a lovely evening.